Good afternoon. I'm Dr. Lisa Tartaglia,
Dr. Sarah Bone.
and we're here today to discuss when patients receive the news that they are not a surgical candidate.
I mean, that can be really upsetting to hear, and it's a very complex process to evaluate somebody for surgical procedure. And when a surgery isn't offered as an option for disease treatment or management, it's really an upsetting thing to hear. There's a lot that goes into getting that medical clearance. And sometimes it's not straightforward or doesn't seem like it to the patient, and sometimes it's pretty intricate, very involved process for that determination, because there's a lot of factors that need to be included for that determination. Factors that the patient wants to consider, as well as the person performing that procedure that they need to also consider.
Right, and a medical clearance consists of to do an analysis and interpretation of a lot of data. It includes a history and physical exam that's completed by a physician. There's also lots of testing that's involved, such as a chest x-ray, EKG. You also order an echocardiogram if you have a history of heart problems, and then we normally do a battery of blood work.
Yeah. If you've got a history of a heart problem, or they're concerned about the length of the procedure, or maybe the position the patient is going to be in, they may say, well, the person has a history of heart trouble. We need more data on that heart than just an EKG. So they may want other tests done, and part of that could be from an echo.
Mm-hmm. Oftentimes it's a team of physicians that are involved in the decision-making capacity. There's the surgeon, there's an anesthesiologist, an internist, or a PCP. The internist is usually used when we're doing surgeries that are inpatient. The PCP is involved if the patient is on the outpatient when surgery is determined. And then there's the other specialists involved that might be involved with the surgery. For example, if you were to have a tumor, there may already be a medical oncologist or a radiation oncologist already involved in the care. But the main person that really should be involved is the patient. What does the patient really want?
Yeah. And so they assimilate all this data that they gather, and then each specialist talks about the risks from their viewpoint. And the surgeon is the one who's going to be doing that procedure, doing that surgery, doing that intervention, and they have to look at all of the data and all of the risks from each of those other medical specialists and decide, is this a risk that I as a surgeon am willing to accept on behalf of my patient? Because I took an oath to do no harm. And if I know that the risks involved are significant and there's a high probability of a bad outcome, the surgeon may say, this is not something I'm willing to offer because I don't feel like that risk-benefit ratio is in favor of the patient, and it goes on my record too. I have to lay my head down at night on the pillow, and I have to feel good about what I've done. And just a patient saying, I'm willing to accept that risk, you just do it. We're not car mechanics. We are taking care of people, and we did take an oath to do no harm. So some surgeons may say this isn't a risk that they're willing to take.
Right. There are some patients that will not pass the testing, and that's usually due to complex medical conditions involved in their care, and they're deemed not surgical candidates, and that's because their risk outweighs their benefits. And from the standpoint of the person doing the surgery and all other collaborating physicians, it will do more harm to the patient and may cause them to have a worse quality of life in the outcome.
So maybe the surgeon finds that the risk is not that significant, but then when the anesthesiologist interviews the patient and they find out what happened the last surgery or the prior two surgeries, maybe there was a side effect with the anesthesia, maybe the patient had a bad outcome after the last one, the anesthesiologist may say, I don't think this is a good thing to put this patient under. So the anesthesiologist may be the one that says that this person is not a good candidate. Maybe they don't feel like they can ventilate the person. Maybe it's not just a side effect of the medication. Maybe it's the ability of the machine to ventilate that patient safely for the duration and or the position that the patient has to be in during that procedure.
The verbiage of hearing you're not a surgical candidate can be very daunting to many people. It's so upsetting because it means you cannot have it. So what does that really mean?
It's really puzzling. And if I can't have it, what does that mean for my outcome? What are you going to do instead if you can't cut on me? Then what can you do for me? Is my situation going to get worse? Do you have something else that you can offer me instead?
Or is it just, is this the means to the end? Like, do I need to start preparing for end of life because this surgery risk is so great that I cannot have it, but I have a metastatic cancer, and I may not also qualify for other medical treatments?
Maybe at the time of diagnosis, the initial staging led the surgeon to believe that there was only one site involved, and that was the only surgery was just for that one site. And then when the final staging is complete, they find out that there are other areas of involvement, and so surgery may not be the best option at this point. Maybe it's not that you're not ever going to be a surgical candidate, but maybe they have to do some other treatment first before they offer that surgery.
There are many diseases that we look at to view whether or not you're a good surgical candidate. We look at patients that have heart disease, chronic obstructive pulmonary disease, dementia. Do they have any liver problems, which would cause a blood dyscrasia? Are they having any problems with renal impairment that will affect anesthesia and also outcome to surgery depending on the location of the surgery? How is their diabetes? That affects healing. If their diabetes is out of control, it's very hard to heal with a blood sugar that's out of control.
So each one of those disease processes has specific workup requirements that are involved with it, with evaluation and testing. Possibly your blood sugar, as Dr. T said, is not under good control, and maybe they say before you have this procedure, your blood sugar has to get under better control. So maybe you've always been managed with oral medications and diet, and now they're say for the next month, the next 6 weeks, you're going to have to manage your diabetes very carefully, and you're going to have to be on insulin because they want to see your numbers improve before they administer those medications and put you to sleep to do a surgical procedure and intervention, because it does change your risk and change your outcome, especially with healing.
Physicians need to take the time to look at the patients pre-operatively, look at the whole patient, so you're able to create a great picture and decide how the patients will do post-operatively. And what I mean by that is for patients that are not very high functioning, they're not able to get up and do their normal activities of daily living because, well, be it maybe because of a functional change. Could it be a cognitive change? Could it just be their body habitus? They're morbidly obese and they're not able to do a lot. How will that outcome, how will that surgery affect them because they're already debilitated? You have to really look at the patient globally. This is not something taken lightly. It's very serious.
If you've got a patient that's not very ambulatory already and they're going to have a procedure done, you know they're going to be kind of down and out afterward for at least a day or two. And for every day you're not mobile, you need anywhere from 2 to 5 days to regain that. And so if you lose ground and you're not mobile, it could really interfere with your ability to recover, and it could make your recovery even slower because you're not mobile. So you might need to be in the hospital for a couple of days. You might need rehab afterward because you've lost some significant ground during that procedure. And if the surgery was for removal or an amputation, then it's really going to be, a period of time for that area to heal and then you to be able to regain significant mobility.
Right. Surgery is not easy on the body. It disrupts our normal equilibrium. It affects all of our organ systems, and it can change our health care status and baseline forever. You may never return back to your normal baseline, and it's really important that your physician really emphasizes that.
There are a lot of risks associated with surgery in general. There can be blood loss, low perfusion, your blood pressure could drop during the procedure, and the anesthesiologist is managing all of that, and it might be a CRNA, a certified registered nurse anesthetist, that's managing you with an anesthesiologist coming in and out of the room because they're monitoring all of your vital signs and your oxygenation and your heart rate and your blood pressure while the surgeon is busy doing the surgical procedure. So if you've got a circulation problem to your heart and for some reason you have an intraoperatively or a post-operative heart attack or stroke, that can be, extremely devastating for a person and, that loss of function.
Yeah, we already touched a little bit on anesthesia and what that can do to affect you, but it has many side effects, and you just have to really bear in mind when you're working with somebody that's already cognitively impaired what that anesthesia will do to them. And then a very common side effect that's awesome, just like, oh, well, that's going to happen, is nausea. But that can be very dangerous when we have an airway protection during a surgical procedure. You could aspirate if you are to vomit, and that will cause infection and inflammation in your lungs.
And they want to protect your airway, so some surgeries they have to intubate you, and of course that's a risk to your dental stuff because they could, chip a tooth or damage a tooth during that procedure of putting that intubation. They're giving you a lot of chemicals to sedate you, to paralyze you, to put you to sleep because they don't want to just paralyze you and you're awake for the procedure. That would be pretty horrifying. But they want you to be asleep and paralyzed so you're not trying to fight or move, but you're fully at rest, and that's why you need to be on that ventilator during the procedure. And they need to assess your lung function, and can that machine ventilate you? Do you have a problem with the medications that they're going to use for that?
Right. Infections is a big complication that can occur after surgery. Oftentimes it presents itself as a urinary tract infection. It can be pneumonia that presents itself, and the big thing is you want to make sure that it does not become a systemic infection such as sepsis.
Yeah, you're going to get an infection at the site, and then that can go into the bloodstream, and then it goes through your body, and you can get sepsis from it. So sepsis is certainly a risk.
Pain is really important to control. People take that for granted. They just think, okay, I'm going to have surgery and, I'm going to get my knee replaced and it's not going to be painful. It's going to be very painful to have your knee replaced, and you need to be up and walking right after surgery. So pain management is very important to control.
We've also touched on the respiratory issues, but if a person already has, some lung damage, some COPD or interstitial lung disease, and now they're more susceptible to an infection because sometimes something called atelectasis, where those little air sacs are not open like they should, and then the body will try to fill those flattened air sacs with fluid, so infection in the lung can actually occur, and a lot of respiratory issues can happen.
Yeah. Difficulty using the bathroom can be defined as people that have trouble from the anesthesia. You might have a bladder emptying issues, so the bladder may remain full, which can cause a site for infection. And then the big thing is constipation. Constipation can be caused from the anesthesia side effect, also from the pain medication. So you really have to make sure you're looking at a great bowel regime going into surgery and having that proactive conversation with your patient before surgery, so we know to prevent postoperatively.
Issues with bleeding, either clotting because it's too thick or bleeding because it's too thin. I know years ago that they would just tell you the risks of the procedure are bleeding, infection, and even death. And they would just kind of give you those three things are the risks. Do you want it? Here's the piece of paper, sign here. And it's gotten to be a lot more involved process than just saying bleeding, infection, and death, because it is more involved than that.
Right.
And I'm glad to see that we've made that progress, that we're including the patients more, and we're doing better evaluation for that risk of surgery.
Yes, for any surgery, whenever you're immobile for a long period of time, it can even be a day, you lose body mass, and the most important thing that you lose is protein. So it can change your nutritional status and your ability to heal if you don't have good protein. So the loss of muscle mass and mobility is really important with surgery. So oftentimes right after surgery, they want to get you up, they want to get you moving. So it's very important to be evaluated preoperatively as well as postoperatively.
Now, there's different types of surgeries, and by that I'm talking globally. There's minimally invasive procedures as well as open or more invasive surgeries, open surgeries. So certainly it sounds, like any kind of surgery is, a serious procedure, but just because something is listed as a minimally invasive surgery, it doesn't mean that it is without risk. There are certainly risks in minimally invasive procedures. Can you talk about some minimally invasive surgeries?
Sure. Well, there's laparoscopic procedures that are done with a camera. They're actually very cool, and they're done with camera and other devices to go in and remove different organs. Like, so for example, you can have a laparoscopic surgery to remove an ovary, to remove a gallbladder, to remove an appendix. And then arthroscopic surgery are very similar to laparoscopic because, again, it uses a camera, but that's done at a joint. Another type of surgery that's minimally invasive is like an endoscopy, colonoscopy, that you can do biopsy removal with either of those procedures.
Yeah, EGD where they look in your stomach, or the colonoscopy where they look in your colon. Your swallowing tube goes into your stomach, and then there's like 22 feet of small intestine that just kind of goes back and forth like a sack of noodles. And then you've got your large colon that starts in the right lower corner of your belly, and where that your large colon and small colon meet, that's where your appendix kind of hangs off there. Then your large colon comes up the right side, goes across the top, sort of the front of your back, kind of behind your stomach, but in front of your back muscles, down the left side, makes that S-shaped curve and goes out. So the colonoscopy is for that bottom 3 feet. The endoscopy is kind of for the top 2.5 to 3 feet. And sometimes they need to look in the small intestine, and they'll have you actually swallow a camera to take pictures. Now, you can't have anything in your colon, anything in your stomach, anything in your intestine, or it's just going to get pictures of poop. Yeah. And they know what poop looks like. So they want to see what does the inside of your tummy look like, and it's going to have like a little flash camera, and it's a time eclipse or time released picture, and they'll get a picture of that entire small intestine, but they can't do biopsies with that camera.
No. There's also a way to look with a camera for a bronchoscopy. And a bronchoscopy goes down into your mouth, down into your trachea, and then into your bronchus and into your lungs. And you can actually do a biopsy via bronchoscopy. Certain spine procedures are minimally invasive. Other organ systems, as we discussed, that can be done laparoscopically, you can also do a biopsy that way.
And then placement of certain medical devices they can certainly do. Whether it's they've, put something in for your aneurysm, or they've placed a port, or they've got a Plerex drain that they've put. They've, done certain cardiac procedures, maybe something for a valve, or you needed a stent for your gallbladder, or a stent for your kidneys. Those are minimally invasive, and if anesthesia is given, it's not very much. Even sometimes carotid procedures are done. So there are a lot of minimally invasive surgeries, but it doesn't mean that there are no risks with those.
Yes. And open procedures, or just open surgeries, are generally more invasive. This is usually done when you have you have a cancer diagnosis, and you're going after to remove the cancer and to do the staging. They would normally be done open.
And you get a big scar.
Huge scar.
Big scar with an open procedure, like a bypass. They used to, those used to be very very common, and now they found other ways to do those open procedures rather than, a big bypass surgery. Maybe they did a gallbladder procedure and it was really complicated. Maybe there was scar tissue. Maybe your anatomy was a little bit different, and instead of being able to complete it with a laparoscope, maybe they had to open it. They do some hysterectomies through minimally invasive, but sometimes those have to be done open.
So as you can see, surgical evaluation can be very complex. It requires a team effort of physicians and clinicians to evaluate the risks involved prior to the surgery. Patients need to be patient and trust the process.
Patients need to be patient, and trust the process. That makes a lot of sense. But you also have to be able to be involved. Ask those questions. Have a timeline in mind, and maybe make some notes. I always advise patients that have complicated medical situations or they have serious illness, get a notebook together. Start keeping test results. Start, making just like a journal, not necessarily every single thing every single day on every single page, but just maybe on the left side have this happened here, this happened here. So you kind of have an idea of a checklist that's going to be, what I have to do, what's my to-do list. Be your own advocate, and if you feel like you need help, certainly involve a trusted family member or friend that's going to help you keep track of all of this, because it's pretty complicated.
Yeah, and it's very heavy on you mentally, and then you're also going to be physically drained from the surgery. Make sure you take the process really seriously. Surgery is not something you should just say, oh yeah, I'm just going to go have surgery. Look at the whole picture, take it seriously, listen to the results, ask the questions, And then always make sure that you have a healthcare team member that you really trust that could help you make the decision.
Who's responsible for this? Because I saw a cardiologist, I saw a surgeon, I saw an anesthesiologist. Who's really the one who's making this decision with me? So you're not going to say, yeah, I want it. Each one of them has a stake in this, but who's really the one who's going to make the final decision with me?
Yeah. And being informed that you are not a surgical candidate carries such hidden complications, implications, and can be really quite upsetting. So make sure you have someone within your healthcare team, family members, friends that you can lean on through this process. It's a very difficult process. It should be taken very seriously, and know that there are other options out there, such as maybe seeking advice from a palliative medicine perspective.
If you've been told this, please obtain assistance from your palliative medicine team, as this does imply that you have serious illness. Please watch some of our other videos in our serious illness playlist that is located on our channel site, and you can just watch that whole playlist if you like.
Yeah. I want to thank you for joining us this afternoon. I know that this topic is often really difficult to receive this news. It's not to be something taken lightly, and we're here to help you.
I want to provide that support for you.
Yes. Thank you so much for joining us.
Bye now.
Bye now.